At Dr. Reddy's and Nestle, we believe in empowering lives through evidence-based nutrition. And I think one of the key objectives we have is to drive the conversation on importance of nutrition in different therapy areas. And today we'll be talking about one such very, very important need in many people's life, which is the ICU. People who are critically ill, who are admitted in ICU. How does nutrition play an important role in impacting the patient outcome? And we have a stalwarts here, very experienced critical care specialist, and also a very senior clinical dietitian. So I think this is a great panel to have. And without making it any further delay, I'll start. And before I pose these questions, I think just a couple of thoughts for you to know that nutrition inadequacy or poor nutrition status of ICU patient. Now, why it is so important and why are we discussing in a healthcare forum about nutrition is because multiple studies across the world have shown that the poor nutrition status in ICU result in delayed recovery, increased hospital length of stay, increased healthcare expenditure, which is largely out of pocket. This is not under insurance in many places. So this is something very, very important topic from overall healthcare perspective as well. So with that, I'll start with Dr. Yatin Mehta. So in an ICU, there are so many priorities intensivist needs to handle. So among all those priorities, how important it is the nutrition management and why it is so important?
See, Nandan, nutrition is now considered one of the vital signs. Okay, so it is unfortunately most of the times we try to establish a diagnosis. We start some antimicrobial therapy because sepsis is a high reason why the patient is admitted to the ICU. We'll look at his hemodynamic status, start vasopressors and so on and so forth, and source control. But very little, unfortunately, attention at the moment is paid to nutrition. So we need to increase that. Also, most of the tertiary care hospitals, now if you look at the admission, I mean, there's multiple Western papers, but there are a few Indian papers which have emphasized this. And one paper from Calcutta, it showed that about 85% of the patients admitted to the ICU with cancer were malnourished on admission. 65% with COPD, chronic lung disease, had malnutrition. 74% of the patients with chronic liver disease were malnourished on admission. Now, a patient who's malnourished when admitted, every week of stay is going to increase his malnourishment status by about 20%. So we do not pay enough attention to it if the patient is malnourished. Again, one surgical series had shown that the complication rate is 3 times more when a patient is malnourished, and the mortality is 4 times more when a patient is malnourished on admission. So I think we have to emphasize that this is a very important aspect of the clinical care of the patient, which is significantly going to affect how many days the patient is going to stay in the ICU and the hospital, how his wound is going to heal, how he is going to get secondary infection, because immunodeficiency is a problem in this malnourished patient. His gut is not going to move well. And we think that we are okay when the patient is discharged from the hospital. He'll probably get worse at home because we think we will give some clear soup and the patient will get better. So I think this is a grossly ignored situation. And if the incidence varies in the ICU from 40% to 80% in the Western literature, you can imagine how much it must be in the Indian setup, because many of us are vegetarians, and many of with these chronic illnesses, last thing on their mind is nutrition. I think they just want to get better. So I think it is not only, obviously we are in a healthcare scenario where we are looking at the cost and the expense to the patient, which is substantially going to go up if your patient is malnourished. And therefore, early diagnosis of malnourishment, like early diagnosis of sepsis, is important. Assessment of this patient by new technologies, which we'll come to that a bit later, and early intervention is important in these patients.
Absolutely, I think, and you made a very right point about early diagnosis of nutrition status. So with that, I'll come to Dr. Radha here, who's a clinical nutritionist with a lot of years of experience. So how do we measure this malnutrition, and how important and why it is so important to screen and assess the patients?
Thank you, Dr. Nandan. It's very, very important that we look at screening and assessment of these patients, because we have to remember that there's always malnutrition in the community, and it is these individuals from the community come with a disease to the hospital. Identifying whether they are malnourished or not at admission is essential, because we need to initiate nutritional care, nutritional intervention as early as possible. It's a red flag that you have to create to say that these are patients who are at risk, and so extra care has to be given to them so that they do not deteriorate. There are different ways where there are different tools that you can actually use in the hospital setups, where you can seek screening, do screening and assessments. There have been traditional methods, and the most common method that was there was SGA, but what we have now is called as GLIM, Global Leadership Initiative for Malnutrition, which is globally a common tool that is being used in the hospital setups. And why is it very essential to use this? Because there is a subjective element in it and an objective element. Because gone are the days where we use to say that the patient is not good or underweight or overweight or obese or normal, but now along with BMI, what we use is body composition to identify whether the patient is well nourished or malnourished in terms of body composition, and that also helps us in trying to identify or dictate what is the kind of nutrition intervention that we have to give these patients depending on their body composition. And that's what we do at a regular basis at the hospital, and that's an essential part. And achieving this, what is most important is in the healthcare setup, as we have the ratio of how many patients does a doctor see or a DMO sees, and how many patients does a nurse see in an ICU, nurse sees in the ward. Same thing, a ratio has to be created for a dietitian. That is never done. So if you want nutritional care to be given across all the patients in the hospital, then you have to identify what is the ratio of dietitian to patient, because that will tell us what level of nutritional care and intervention can be implemented for the patients.
Absolutely. I think you made a very valid point, and we'll explore and we'll talk about that a little bit later. So from diagnosis to now, when we say we have, what kind of clinical outcomes nutrition impact, I think it's very, very interesting conversation for the audience also to know. So I'll go to Dr. Diwatiya. So sir, can you explain in your experience, what are the clinical outcomes impacted by malnutrition, and can giving the appropriate nutrition, those measures can be corrected?
Yeah, so thank you again for having me here. So yes, I think it's reasonably common sense that if you don't eat, you will have problems. And there is data now to support that sort of common sense assumption. So let's say Dr. Mehta talked about muscle mass is reduced. So roughly every day that you're in ICU, you lose 1% to 2% of your muscle mass, right? And it is safe to say that even if someone is not malnourished, anyone who stays beyond 48 hours in ICU needs nutritional intervention. Okay? If you lose about 10% of your muscle mass, your immunity goes down. You lose 20%, you get more and more infections. You get 30%, you become so weak you can't move. Difficult for you to get off the ventilator. So, you stay longer in the ICU, stay longer on a ventilator. And if you lose even 40%, your chances of dying are much higher. And many studies have shown across different subgroups, whether it's stroke, whether it's head injury, whether it's cardiac surgery, GI surgery, the more malnourished you are, your mortality goes up. Not a huge amount, 10 to 12%, but your days on ventilator go up, your stay in ICU gets longer, your costs obviously go up, and that sort of thing. So it's safe. So there is an association of malnutrition and muscle loss with worse outcomes. The next question you asked is actually very important. Can giving nutrition actually reverse some of these things? And here the answer, I think, is a little nuanced. In the first 2, 3, 4 days, when you're really sick, you've got sepsis or you've got a major trauma or you had a massive operation, the body doesn't really absorb whatever you give it. So even if you try and push a lot of nutrition, it's not going to make a huge difference. And some studies have shown that if you try to give too much protein and too much carbohydrate in those first 2-3 days, you would actually have worse outcomes. So you need to be a little careful in the initial 2 or 3 days of a very sick patient. But beyond that, giving protein, giving carbohydrate, stepping up gradually, doing it in a proper graded fashion actually can improve outcomes. And I think the crucial period is somewhere around between 1 week of critical illness and to about 2 weeks or 3 weeks. That's when you really need to step up, because as the body is recovering, that's the time when it starts accepting more nutrients, metabolizes more nutrients, and you can actually get your better outcomes. And very importantly, even after the patient is discharged from the ICU, whether to the ward or it's the home, that's the time the body is now recovering and it's in a sort of recovery phase. And that's really the time you need to make sure nutrition doesn't stop. They say, we ghar aa gaya, now we'll have dal chawal and he'll be okay. But that's the time he really needs nutrition supplementation so that the rest of his recovery is better and he recovers his muscle strength and he becomes more functional, faster, and with better functional capacity. So I think nutrition plays a very important role, but there is a sort of nuanced view that you need to know when to start, how much to start, and when to step up.
Absolutely. I think you made a very valid point, which is also very important from an overall healthcare perspective, is after discharge, you need even better nutrition. Otherwise, the data shows that a lot of people come back to hospital with readmission because of the poor nutrition status. And sir mentioned about calories and proteins. With that, I'll come to Dr. Harish. So this, can we really measure, are we giving adequate nutrition to these patients? The term we use now, nutrition adequacy, right? Is it possible to measure it, and why it is so important to measure it?
See, basically, as we know that in India, so the health, what we are going to provide, it's a diversified thing. So someone may practice in a tertiary quaternary care center, some practice in a trust-based hospital, medical college, community-based hospital. But when we deal with a tertiary or a quaternary care hospital, they are already off-treated in the community kind of this one. So when there is no concept of nutrition in the community-based hospital, when we take them in an intensive care unit, so we need to match their requirement. So what is the supply, what is the demand kind of this one, okay? So basically on an average, we give around 20-25 kilocalories per kg per day of the energy, that is the calories, and protein of around 1.5 to 1.8 gram per kg per day of the protein. So in the initial days of their criticality, lots of catabolism will be there. So there is a muscle breakdown, okay? So you need to understand disease is very, very dynamic. So one day they will have a high grade fever, their oxygen requirement will be very high, they require mechanical ventilation and all. So one day we dialyze the patient. So it's very dynamic. So if you dialyze, on that day we are going to remove lots of protein, lots of carbohydrates, kind of this one. So their need is going to be fluctuating. So you need to measure their daily requirement based on their criticality of the illness. So when there is a gap, even in best of the best scenario also, we are able to reach maybe around 60-70% of their protein and that of the calorie. So if you are not matching their requirement, so it's going to get accumulated by the end of 1 week. We know that in the initial 5 to 7 days, our target for like calorie energy is around 50 to 65%, but we need to match the protein. So if you don't manage and measure what we are calculating and what is going to be delivered to the patient, so then that gap is going to be widened and it is having an impact in terms of morbidity, mortality, infection, ICU length of stay, hospital length of stay, ventilator days. So ultimately it will compromise everything in terms of the healthcare setup. So what we practice is on day-to-day life of a critically ill patient. So we calculate, so what is its protein and that of the calorie requirement. So is it matching in terms of their disease status, and we are able to achieve the delivery. So that will keep on calculating and it's get measured over a period of their ICU stay and all. So what we can do to address all these things, because the problem is, one, if you delay in initiating the nutrition, so then obviously you are out of the race kind of this one. Even though you initiated the nutrition with taking care of appropriate protein and calorie, there are lots of interruptions will happen in critical ill patient, because I need to shift the patient to say radiology for MRI. So or I want CT scan, or we want to do bronchoscopy, or we want to plan for removing the ventilator, removing the tube and all. So or maybe patient is scheduled for some sort of elective, semi-elective surgery and all. So lots of interruptions we are going to do. And even you calculate protein and energy, and if you try to deliver, patient might not tolerate so much of quantity, because there is something called feed intolerance. So they might omit. So there might be increase in Ryle's tube aspirate. We put a one tube through the nose or mouth to give the nutrition. So they might not tolerate. They might have a diarrhea. So all these things are contributing, one, delay in initiation, or interruption, or intolerance. Again, your gap is going to be widened. So how we are going to address all these things? We have a very good published data and all these things in a stepwise, in a protocolized way, which is backed up with a very good evidence. We have something called PEPA protocol, catch-up protocol. So there are commercially available some feed products, so which are semi-elemental, which makes critically ill patients gut to absorb, gut to digest easily, like peptamine. Okay, so these molecules definitely serve the purpose in terms of like closing this gap of what we calculate and what we are going to ultimately deliver, so that we can reduce the morbidity and mortality. Overall, we can reduce the direct and indirect cost of like critical ill patients in Indian scenario, which is very important, because one day extra stay in ICU is going to cost too much. So it may be a month's salary for a particular patient. So that we can avoid if you are able to take care and close the gap of like what they need and what we are providing.
Yeah, I think beautifully covered. I'll come to now Dr. Himal. So, it's very tricky when to start, etc. But what is the importance of starting the enteral nutrition, which is what we commonly like to discuss? What are the advantages and how it really benefit the patient? If you can elaborate a little bit from your experience.
So I think just to add up to that, so why are we here and why are we talking about this particular aspect? All the clinicians here coming here and talking about nutrition, as rightly said, in terms of health economics, if you think about it, even a 1 day of ICU stay, they said length of ICU stay, number of days of ventilator, it is going to put a humongous impact on the patient's money, the resources, the healthcare resources, as well as the insurance problem. So that's why if you add up every day in the multiple admissions across the hospitals, it is going to be a huge burden. A simplest intervention, just like early enteral nutrition is the key, is going to reduce this cost for all across the stakeholders, because over the time the studies have proven that if you give early enteral nutrition to the ICU patients, especially critically ill patients, it is going to improve the wound healing, actually improve the muscle mass, and also reduce the number of stay in the hospital, as well as when they discharge out also, it's going to get better. So just to put a point across, we talk about big things here, but there are still certain setups which follow, not the good for feeding formulas. They follow kitchen feeds, thinking that they can bring down the cost of the patients. But overall, they're actually compromising the patient safety, probably by increasing the risk of infection. So as rightly said, there are certain products like your peptamine products or peptide-based formulas which are well tolerated by the patients. If they tolerate that well, their recovery is faster, and overall cost is going to cut down significantly, much lower. And we have seen our experience-wise, these patients get shifted faster out of the ICU, and the bed becomes available for the next patient. So if you look at the overall economic factor, it is going to be definitely beneficial for the entire across, for the hospitals, for the patients, as well as for the healthcare insurers also. So a simple intervention like nutrition is going to do a lot of impact in terms of health economics. Your early enteral nutrition is definitely a key, and it is one of the major morbidity and mortality marker in the ICU. Just like how important an antibiotic or a ventilator is, nutrition is as important to us in the management of the patients.
Absolutely, I think very well said. And now this is easier said than done. So my next question is to Dr. Saurabh. Is what are the challenges and barriers you face, especially when implementing all these nutrition protocols? Is it cost? Is it lack of multidisciplinary approach? What is it?
So thank you, Dr. Nandan, for giving me this opportunity. So as has been told by my previous panelists, nutrition does impact outcomes. It reduces the cost and the length of stays. and we know assessment and screening are very important, but still implementation is patchy. So we'll be talking about the barriers. What are the barriers and why it's still patchy? So the first thing that comes to my mind is staff training and awareness. So we all know that nutrition is important, but we do not have any formal training in nutrition during our courses. We do not give it importance as fluids or antibiotics or ventilator. So we as a team, all the healthcare providers, all the different specialties that take care of the patient, the nursing staff, should receive some bit of bedside teaching, some bit of workshops, some simulation-based modules, so that we all know why is nutrition important. And once it is drilled in all our minds that nutrition is important during our formative years and during our continued medical education, then probably we'll give more attention to as soon as the patient comes, as soon as he is resuscitated or settled in the ICU or the critical care settings, we'll provide him with adequate nutrition or think about providing him with adequate nutrition. Then the second point that comes to my mind is monitoring and assessment. So we all prescribe nutrition, but do we actually audit whether what we have prescribed is correct? What we have prescribed goes to the patient. So studies have shown that around 60% of patients only are given adequate nutrition what we have prescribed. And that too only up to a mark of 60%. So realize that a majority or a vast majority of patients are not given adequate nutrition, although previous studies have shown that they are malnourished when coming to our ICUs and suffering from different illnesses. So now all the major hospitals have EMRs. So we can have a nutrition dashboard on the EMRs. We can have checklists, so that we really know what we have prescribed is going to be given to the patient and whether he is actually tolerating it. So nutrition tolerance is also very important. Then comes cost and resources. So various equipments are there for nutritional assessment, and they are definitely costly and not available at all the hospitals. Sometimes not in the tier 2 or the tier 3 cities. But luckily for us, the guidelines have shown that when we start early enteral nutrition in a very standardized format, and we try to meet the enteral nutrition goals within the first week that the patient is in the ICU, we can actually decrease the mortality or at least improve the stay of the patient. Then the last is we should interact with each and every specialty that is involved. The gastroenterology, the neurology, nephrology, pulmonary medicine. See, all of them can act as nutritional champions. They can, if they are emphasize the role of nutrition and the patients come to ICU, even their fellows, their colleagues, their juniors, they can all know about nutrition. And when we all talk about nutrition, the more the awareness is there, the better will be implementation. So although there are definitely barriers, but they are all surmountable.
Absolutely, I think very rightly said. And in the interest of time, I'll come to a very quick rapid fire kind of question. Is in terms of, we discussed about the impact the nutrition can make. We discussed about the protocols. If we can have it protocolized, it will be very, very helpful. We understood the challenges. We understood the clinical outcomes. We also talked about the resource limitations, right? If we have to implement one thing, right? One thing, if you want to say, that is very, very critical in driving the nutrition adequacy in ICU so that the patient outcome can be better and overall healthcare outcome can be better. What is that one thing? I need answer in one line. So I'll start with extreme right. So Dr. Mehta.
See, I think it is important to have nutritional management teams in every tertiary care hospital at least,
Okay.
which consist of a clinician who's treating the patient, intensivist maybe, a nutritionist, a nurse who's involved in nutrition, and most important, an administrator, because we need their support for the resources.
Absolutely.
So I think that is what is most important, and we must begin with that.
Sure. Thank you. Dr. Diwatia?
Yeah, so I think a nutrition support team is a great idea. Every patient must get nutrition. Focus on enteral nutrition, that is either through the oral route or through a tube, because that is cheap and it keeps the gut going. And step up your nutrition in a graded fashion, reach your goals and measure your goals, and I think that should be it. And secondly, nutrition is to be combined with physiotherapy, combined with mobilization, and if you do all these things well, then I think you can get very good outcomes out of good nutrition and good general care in the intensive care unit.
Sure. Fantastic. Dr. Harish? Yeah.
See, with the nutritional support team, take all the stakeholders together. So including a nursing staff and a surgeon or other clinician who are like stakeholder in terms of admitting a patient into ICU. So create a myth buster, so create awareness, and very, very important, consistent follow-up is very important. So what's happening to the patient, what you are ordering, so what is delivered or not. So
Yes.
that you need to take care.
Sure, sure. Dr. Imal.
Yeah, I think
In one
everybody
line.
should understand that it is a therapy and not an afterthought. So be more proactive, use more proactiveness in selecting the feeds like peptide-based formulas. Use some tools like gastric ultrasound, muscle ultrasound, optimize the therapy and get the patient out faster so you can reduce the burden of the healthcare costs. Yeah.
Absolutely. Thank you.
So my takeaway will be measure what you do, document what you do, and actually with the help of data analytics, analyze now. If we analyze and we re-audit what we do, we'll improve on whatever, be it nutrition, antibiotics, anything else. Same goes true for nutrition.
Final comments, Dr. Radha.
Every hospital should have a nutrition support team, which is very, very strong, along with a nutrition steering committee, who will audit, share, improve, and then keep going up. This is very, very important. We need to audit every month. Look into what are the loopholes, go ahead with corrections, do the kappa, do corrections, and then keep going up. Because the very fact that we should believe that it's not right to food, but it's always right to food and nutritional care for everybody in the hospital.
Yeah. Thank you so much. I think we are already, time is up, so we will stop here. Thank you. Thank you once again.